What is spinal stenosis? We're going to illustrate what lumbar spinal stenosis is by way of a case. So this is a 66-year-old female who came to us with pain and heaviness in her legs when she'd walk more than 2 blocks. She used to walk on the beach every day, and she was really getting discouraged with how little she was able to walk before she got this heavy tree trunk-like sensation in the legs. We call this neurogenic claudication. This is a really typical presentation of someone with spinal stenosis in the lumbar spine. So what does their imaging look like? If we look here, we can see that the diameter of the spinal canal is normal. Now it's not spinal cord, these are just spinal nerves at this level. But as we scroll down, right now we're at about the L3-4 level. As we come down to L4-5, we can see that that is severely narrowed. It's starting to look like triangular. We call that trefoil stenosis here. This here is ligamentum flavum. We call that ligamentum flavum hypertrophy, and that's starting to encroach on that canal. And every time she leans back or stands up or walks, that ligamentum flavum starts to buckle. It starts to push in on these nerves that are already very congested in there. So what does she do? When she goes to the grocery store, she leans over. We call that the shopping cart sign. Different treatments that we have for spinal stenosis would include epidural steroid injections or even possibly minimally invasive lumbar decompression. But this is a very classic example, both by history and imaging, of what this patient's pathology is, which is spinal stenosis.
All right, so Dr. Westerhaus just spoke about what is spinal stenosis and how we diagnose it. So treatments for spinal stenosis usually start pretty generic. We're gonna start with some physical therapy, see if we can get people moving, see if we can get these nerves flowing again and get movement back in that spine and maybe open up some of that space. If that doesn't work, our next step is usually an epidural steroid injection. Either we'll go interlaminar or we'll come transforaminally based on how much space there is. A lot of times with spinal stenosis, there isn't much room to do an interlaminar injection, so we come bilateral transforaminal. What that does is get the medicine all around these nerves, calm down those nerves, decrease the inflammation, and decreasing that inflammation will give those nerves some more space. Now, if those epidurals don't last or don't work, we'll have to go to something more invasive. Not full-fledged surgery, we have to take all this off. That's called a laminectomy. So this is the lamina here, and we have the spinous process. With a laminectomy, we do a cut here, and pull all this off. Well, why isn't that good? If we look on this end, this image, which is a sagittal looking from the side, these spinous process are like bridge towers, and they hold this whole bridge up. So if we take one of these bridge towers out by doing a laminectomy, this level, yes, now will be less stenotic. There'll be more room here for the spinal cord, but the level will also be unstable. So a lot of times I do laminectomy and fusion, which will put some rods and screws to try to give that stability back. But then we end up with adjacent level disease where these levels above and below, so here we're talking about L4-5, at L5-S1 and L3-4, now we'll start to break down. So do we have things that are less invasive than that? And yes, we do. We have something called the MILD procedure, minimally invasive lumbar decompression, where we can go in and actually core out some of this ligamentum flavum, very minimally invasive procedure. We go in from each side, first on the left, shave down some of that, come back out, shave down some of that, and that'll give some space back. Get rid of that pain when the patient's upright. They won't have to lean over as much. Then we have some widgets, we call them, that we could put in. First one is Vertiflex. Vertiflex goes right in, kind of props up the spinous process, gives you some of that space back. Now there's no stabilization with Vertiflex though. A newly FDA approved device that we have for spinal stenosis is called the Minuteman device. And what the Minuteman device is you come in laterally. You actually make a little scar laterally and you go stay posterior. So this is posterior, this is anterior. We stay posterior and we actually grab on to the spinous process. The things that we remove with the laminectomy, we actually grab onto them and we put a little space here that opens up that space. And if you can think of this as a buckling here, as we open up that space, that buckling kind of straightens out. So we open up this space with the Minuteman device and we clamp it together, and that gives us that stability. So not only are we opening the space, but we're giving that stability there, which will open up this area and give that patient long-lasting relief. Why doesn't this cause adjacent level disease? People always ask me. Well, we're not taking the lamina off. We're not taking down all these inner spinous ligaments. The patient still has that bridge in every tower there. And the Minuteman device is much less invasive. So we have a lot of options to treat spinal stenosis, but the main goal is to open up this area and try to make it look like their normal spine, which is up here. You can see nice open area, spinal nerves, very happy spinal nerves. And as we come down here, all closed down at L4-5. So the goal is to open up this area with the least invasive way we can. One, physical therapy. If not that, injection. If not that, we go to a minimally invasive device. And if that doesn't work, then we go to laminectomy and fusion.